Kenya National Commission on Human Rights. We are a constitutional body established under Article 59 of the new constitution, charged with the mandate of promoting and protecting human rights in Kenya. To discharge our mandate, we receive complaints of human rights violations, conduct public or civic education, research on various human rights, and advise the government in compliance with its international and domestic human rights obligations. We take pride in our advocacy strength on reforms and accountability, as well as our ability to provide redress to victims of human rights violations.
The Kenya National Commission on Human Rights is a constitutional commission established under Article 59 of our Constitution and the Kenya National Commission on Human Rights Act of 2011. And its main role is really the promotion and protection of human rights in the Republic of Kenya. And for this purpose, therefore, we have both a watchdog role, which means that we monitor the observance of human rights, and then also we have an advisory role, which means that we advise various organs, government ministries, and even private and corporate citizens in matters concerning human rights.
In September 2009, the Federation of Women Lawyers in Kenya and the Center for Reproductive Rights filed a complaint with the National Commission on Human Rights, citing various sexual and reproductive health rights violations in Kenya. The complaint was focused mainly on the Pumwani Maternity Hospital, and it led the Commission to institute an inquiry that would encompass other health institutions and practitioners in order to give a comprehensive report on sexual and reproductive health rights.
We decided to take a corruption of the country, to go around and have first-hand information from the people who had suffered violations. Which violations then, of course, we go to document in a report which we're just about to release.
To set the scope of the inquiry, pre-hearing sessions were held in February and March 2011, which served as precursors to the actual inquiry, which started in June of the same year. The inquiry was carried out in various towns in Kenya, including Nairobi, Mombasa, Kisumu, Kitale, Garissa, and Embu.
These regions were based on considerations like the availability of healthcare institutions, what we call the epidemiology studies, where the prevalence of diseases and such issues which we got from the Ministry of Health. So from there we were able to define the country roughly into regions which had similar issues. So we went here, we interviewed people. Basically we were looking at people as people who access or look for sexual and reproductive health services from the hospitals. We talked to people to hear from them what challenges they face. We also interviewed representatives or heads of these health institutions. Mostly we talk with the hospital superintendent and the matron at the hospital, because these are the ones who manage mainly the maternity ones and other areas sections that deal with the sexual and reproductive health.
Na saa hiyo ulikuwa unazaa watoto wako, wale wengine 5 walikuwa wapi?
Mmoja ni mkubwa ameolewa hapa Kiambu.
Okay.
Mwingine wakati tulikuja hapa sababu ya shida kuwa nyingi, yeye akatoroka. Sasa hizi hatujuagi mahali hapo.
Wale
wengine tunakaa na wao.
There is a saying which was in the Kisi community that those girls who are not circumcised will not be married. They will be married with another tribe. So that idea was in our heads. But when we have known the side effects of we are now escaping from the cultures.
As one of its main objectives, the inquiry on reproductive health has moved to establish the legal and policy framework governing the implementation of sexual and reproductive health rights in Kenya and its effectiveness, determining the extent of sexual and reproductive awareness and its utilization in Kenya, assessing the compliance by the government and non-state actors in the sexual and reproductive health rights in Kenya, and identifying and documenting cases of discrimination in and violation of sexual and reproductive health rights in the country.
Nikauliza nazi, sasa huyu anatakiwa afanye nini? Akaniambia kwani wewe ndio daktari tunamuona? Nikasema ndio, si daktari lakini naona ako na shida sana. Akaniambia anataka apimwe tuone kama tutampeleka dieta. Haya, wakati hiyo kama kitu saa 12 ya jioni nyingine ndio akapelekwa kwa dieta. Kupelekwa huko, kwa vile alikuwa anahangaika sana na anaumwa sana, yeye kuingia huko akatolewa mtoto, lakini yeye mwenyewe akaaga dunia. Sasa
hakutoka theater,
hakutoka, alikufa huko ndani.
Wakakwambia nini?
Saa hiyo hakatoka masista wawili huko ndani. Wakaniambia wao walikuwa wanaongea Kisugu, mimi sijui Kisugu, lakini akasema si mimi nilisema, wakakoroga Kiswahili. Sasa si mimi nilisema asiwe muweke ndawa mingi, sasa anaenda anapasa.
The inquiry process was guided by the principles espoused by the human rights-based approach as stated in the United Nations Population Agency's key strategies of applying human rights-based approaches to reproductive health. These are creating an enabling policy environment that promotes reproductive health and rights, including building capacity to strengthen health systems, partnering with civil society and community-based organizations, and monitoring budgetary appropriations to ensure that reproductive health care is covered. Widening access to comprehensive reproductive health services with an emphasis on disadvantaged groups, building awareness of the reproductive health rights of women, men and adolescents so that they can claim their rights to reproductive health services, encouraging, involving and building the capacity of individuals and communities to participate in the design, implementation, monitoring and evaluation of reproductive health programs and services that affect their lives.
When we went around, the experiences everywhere were more or less the same. The discrimination, the stigmatization, the lack of adequate services seemed to have been more or less uniformly expressed by those who appeared before us.
Insofar as homosexuality is concerned, here that is, I'm also including lesbians. They were very clear in telling us about their health issues, and some of them include, for example, when a gay man goes to seek medical attention in a hospital and he has an STI. One of the things that has been that they brought to attention was that because their STI was in the anal as opposed to the vagina, it would cause a lot of hue and cry. Some of them actually experienced being ridiculed further, because the person who was doing who was examining them, be it a doctor, be it a clinical officer or whatever, would actually go and call other colleagues to come and see this situation and also tell them, and also really humiliate the person further. They narrated that story to us many times. For them, their right to privacy was being affected. For them, their ability to access medical care was being affected. For them, their ability to just keep the issue that is concerning them a secret was also a challenge.
We went round and spoke to women just to give us the experience during delivery, and we got some very horrifying stories all around the country, and these affected both public hospitals and private hospitals. We had aspects of where the nurses or the healthcare providers used very abusive language to the women during the course of delivery. We had aspects of women not able to access contraceptives, either because the contraceptives were not available or the method they wanted was not available within their reach. We had cases where women were not given information to decide. So we have also the right to information. So in most cases, we had sad stories of women who had had their uteruses removed without their consent. And of course, we know that is a procedure that they would require to consent before it is done. In a few of the cases, the men who came out talked about abusive relationships where they also had encountered violations from their spouses, but these were quite minimal.
We had complaints of people who could not reach services because they are too far. We also had people who could not get the services because they complained that there were no staff that that were available at the time when they reached the health facility, or the staff were not kind to them. They were rude. There were complaints of staff abusing patients or even beating patients. We had some women complaining that during labor in the maternity, they would be beaten because they are not following instructions. And this was particularly a complaint that was brought up by people with disabilities, particularly the deaf and the blind.
Article 43(1)(a) of the Constitution provides that every person has the right to the highest attainable standard of health, which includes the right to healthcare services, including a reproductive healthcare.
We need to have a socialization process through civic awareness that makes men part and parcel of the reproduction process. We look that several cultures look at reproduction as an exclusively female affair. That ultimately genderizes the process and indeed then places a lot of responsibility on women, whereas a lot of these should belong to men. In terms of decision making, there's need to have extreme empowerment of women through a community empowerment process that gives them the opportunity to realize that to have access to information, have access to productive undertakings, and also to be responsible in the process of nurturing the children. The other issue would be, as a country, we need a very clear blueprint on reproductive rights and to include culture in the process. A lot of times we look at culture as a hindrance to development, but my view would be that culture is a prerequisite to development, and it needs to be packaged in such a way that individuals for whom we invent certain projects are the beneficiaries.
From this inquiry, we recommend that there's a need for the government working in partnership with all other stakeholders, including human rights organizations and organizations of persons with disabilities, to create and increase awareness on the rights of persons with disabilities, including sexual and reproductive rights. The government must also work to ensure that youth-friendly, non-discriminatory sexual and reproductive health services, including family planning services, are made widely available and accessible to all adolescents in Kenya. In order to handle prevention, treatment, care and support, the government must disseminate correct, reader-friendly information on prevention, treatment, care and support on HIV and AIDS, malaria and tuberculosis, and ensure universal access to both male and female condoms for all sexually active persons, paying more attention to categories of persons with disabilities, the marginalized and vulnerable categories, including sexual minorities and people living with HIV and AIDS. Finally, the government must remove financial barriers that result in the denial of or delays in receiving the necessary healthcare services.
In many health facilities, you get a very skeleton staff. Maybe in a dispensary you may find one, at most two nurses, and they have to do everything. So there is need to increase the number of staff employed at that level. There is need for training, and particularly for training in attitudes. I think if I were to redesign the medical curriculum, I think I would try to make a lot of emphasis on dealing with attitudes, because there's a lot that is missing in the attitudes of medical people towards the needs, particularly of people with special needs.
In order for all citizens to enjoy in full reproductive health rights related to pregnancy, delivery and post-delivery care, Kenya must strive to meet its international and regional obligations aimed at reducing maternal mortality. Kenya's commitment to addressing sexual and gender-based violence is evident through various efforts to ratify international treaties and the formulation of national policies and legal frameworks, as well as implementation of numerous interventions on prevention of sexual violence. The inquiry identified gaps in the international treaties, national policy and legal frameworks that either protect or violate the sexual and health rights of minorities. These findings provide the government and stakeholders with context against which to design intervention and strategies that will ensure that sexual minorities enjoy the fullest level of sexual reproductive health rights. The inquiry concludes that the state bears the greatest responsibility in violations of sexual reproductive health rights of IDPs and refugee persons, and thereby has the responsibility of finalizing the IDP policy and fulfilling the obligations committed through international treaties to fully meet the fundamental sexual and reproductive health rights of marginalized communities. The inquiry concludes that the government has not complied with its obligation to dedicate the maximum of its available resources to progressively realize the right to sexual and reproductive health care.